Good evening and welcome to Second Life CME Pilot, adding insulin in type 2 diabetes. This is an innovative program on Second Life to teach physicians the intricacies of adding insulin to patients failing oral agents in type 2 diabetes. My name is Elliot Sternthal. I'm the Director of Outpatient Diabetes Program at Boston Medical Center in Boston, Massachusetts. You can see me on the left in real life, and on the right, my improved counterpart in Second Life, Islet Sabra. And let's begin by introducing ourselves using the local chat box. Please type in your name, your affiliation, and your specialty. I'll give you a little bit of time to do that. Good. That's great. And we have people from Hungary, Bulgaria, the Czech Republic, and I think we have a couple from Boston. Not so exotic. So next slide, we're going to go through our basic agenda. So we've already done some introductions. I'm going to give you a little bit of housekeeping information. This is going to be a 30-minute talk. We're going to have some interaction with patients, and then we'll have a question and answer session to finish up. So hopefully, by the end of this seminar, you will be aware of insulin inertia. In other words, we don't want you to fear introducing the needle. Hopefully you'll be comfortable in using glycemic patterns to choose which starting insulin program is best for you and your patient. You'll learn to decide among choosing basal or background insulin, prandial or mealtime insulin, or using some of the pre-mixed insulin preparations. And hopefully with this you'll feel confident in titrating insulin. So here's our first question. We said this is interactive. For your patients with type 2 diabetes, when do you generally start them on insulin, and how do you initiate insulin? Please type into your response into the local chat box, please. Okay. Here are some of our responses. Some of you say you're a little reluctant to start insulin too soon, afraid of being rejected by your patient. Some people have lots of fear of the needle, say their patients just won't tolerate starting insulin. And others will use it, will start insulin when the A1C is 8% or more. Well, and others will say, I'm starting with NPH instead of Lantus for cost reasons. So all very certainly common sentiments we've heard before, and let's see what we can do to help you deal with them. So let's talk about clinical inertia on the next slide, which is really sitting tight, failure to advance therapy when it's required. So if you look at these statistics, you can see that there's a great reluctance to treat the hemoglobin A1C to target. Often patients languish for 5 years with a hemoglobin A1C over 8%, and believe it or not, 10 years with a hemoglobin A1C over 7%. And if patients are on diet, you can see that we're a little bit more likely, about 66% of those patients who the doctors feel they are failing will be put on pharmacologic therapy. But if you can see here, if a patient is on a sulfonylurea or a metformin or a combination, a much smaller percentage, anywhere from 18.6 to 44.6%, will be started. So in other words, once patients have been placed on one oral agent or a combination, there's a great reluctance to advance therapy, even if the hemoglobin A1C is above target. So that's a real problem that we've encountered for years. So here's our next interactive question. What's your greatest obstacle to starting insulin? Please type your answer in the local chat box. Some people say expense. I'm not sure of what dose to use. Fear of the needle. Patient fear. Yeah, common sentiments. Anybody for hypoglycemia? That's often one too. I didn't see that just yet, but often fear of hypoglycemia is a big one. Sometimes weight gain as well. Sometimes patients feel that they've failed. Yeah, sense of failure. So we have to prepare our patients to let them know the natural history of type 2 diabetes, and that requiring insulin may be just part of the natural progression. And here's somebody who's really up on the latest. There's some concern that using insulin, such as Glargine or Lantus, may cause cancer. Certainly there's been some recent reports and a lot of news about this association, but certainly this is just very preliminary. These are very preliminary data, and we cannot attribute cause and effect to the use of Lantus and the occurrence of cancers. A lot of statistical issues going on that really prevent that kind of conclusion. So let's talk about insulin use in type 2 diabetes. Certainly because of the progression of beta cell failure, it's not unusual that more than half of patients with type 2 diabetes are going to require insulin to achieve their hemoglobin A1C of less than 7%. Because of the accompanying insulin resistance, insulin doses are usually higher in patients with type 2 diabetes, averaging about 1.2 units per kilogram, much more than we see in patients with type 1 diabetes, who usually need insulin whose insulin requirements usually are about 0.3 to 0.5 units per kilogram. Increasing use of insulin early in the course of therapy for type 2 diabetes has certainly been promulgated. For example, the consensus statement from the ADA-EASD really offers the choice of a basal insulin for patients whose hemoglobin A1C remains over 7% on maximal metformin therapy. And of course, we must individualize insulin therapy for each patient. So on the next slide, we'll just review the actions of insulin. So both naturally produced insulin and exogenously injected insulin find their way into the liver, where they increase hepatic uptake of glucose and stored as glycogen, and they counter the effect of glycogen to reduce hepatic glucose output. In the periphery, when they go into the circulation, they act on receptors on muscle and fat to increase glucose uptake in those tissues. And as well, remember, insulin has other actions other than glucose homeostasis, and it also will impede the breakdown of fat, lipolysis, and protein. So it will inhibit proteolysis, and as well, with its action on the liver, will prevent